Hello, this is Professor Mark Whiteley from Whiteley Clinics in the UK, and I'm going to talk to you about the recent explosion of cheap vein clinics that seem to be hitting the high streets in the UK. And I know it's sort of following the model of other countries, and I can't really talk about other countries, but certainly in the UK I can speak as an expert, as I've been involved in vein clinics now for the last 25 years. I have a big worry about the idea that a lot of these vein clinics are trying to dumb down veins. They're trying to say, look, it's cheap, it's inexpensive, come and see us, we can do it all in one go, and quoting prices up front, which is an absolute disaster, as we'll see. And I'm going to present a patient later on that exemplifies this, and there's going to be many more videos as I've now decided to start coming out into the open and showing this. If you're going to look for cost effectiveness, you have to be sure that the cost is still effective. And the difficulty in medicine is when you start cutting corners to try and be cheap, you end up cutting medical care to a large extent. So you have to be very careful that you're not throwing the baby out with the bathwater and you're not getting substandard care. This is what we're starting to see very much in the vein world. And one of the big problems we have in the UK, as I always go on about, is that the word vascular surgeon does not mean vein surgeon, it means artery surgeon. So when you see a vascular surgeon, you're seeing someone who is specifically interested in arteries and does veins on the side. And you have to also look at the same with radiologists, general surgeons, etc. At the Whiteley Clinic, we make sure that all of our doctors are, whatever background they come from, are fully qualified and to the Whiteley Clinic standards and College of Phlebology standards in venous surgery. And this becomes very important, as you'll see. What we're also seeing now is because these network hospital clinics and because network hospitals, because they all are pushing the prices down and pushing quality down, the insurance companies are starting to come to those of us who are true experts and say, well, we're not going to support you anymore because we can get it cheaper down the road. But be very careful of that, because if you look very carefully, what they're doing is they're then saying, mind you, we'll only pay for the first operation. So of course that means if you've had a bad first operation, as far as the insurance companies say, they're off the hook. They paid for a cheap operation. You're the one who's been left with a problem in the long term, which you now have to fund yourself. So therefore, if you go to whoever they recommend and it's cheap and you think everything's fine and you get your veins back, as we'll see in the near future, then of course the onus is on you. I think personally this is incorrect. I think that doctors and clinics and everyone should be trying to get the very best quality for their patients all the time and should put the patients front and centre. That, however, as we'll see, is not the case. This comes from the fact that at the moment in the UK, the Whiteley Clinic is only supported by one or two of the very best insurance companies, and most of the insurance companies now just support those clinics that do the minimum for the patient. And as you'll see, that's going to come back and bite patients because they won't be covered for any second or subsequent procedure. This is becoming particularly important in those clinics where doctors are keeping the prices down by doing scans themselves rather than having proper vascular technologists doing the scans. Most of the doctors haven't gone through a formal training for this, and so they only look for the two main veins called the great venous and small venous. They don't look for the perforated pelvic veins or anything else. And the case I'm about to present is a perfect example of why that doesn't work very well. So what we're going to talk about this is a patient who, she's 48 years old, and of course she's given permission for us to use her photographs and images because she's so upset about the treatment she's had elsewhere first. When she was 22, she had her initial stripping, and that was done in the NHS. That long ago, that's 26 years ago, that was acceptable because we didn't know much about veins in those days, and virtually everybody got stripping. Since the Whiteley Clinic published the research in 2007, we now know that if you have stripping, the veins just grow back again. So it's a fairly useless operation in the majority of patients. Now, she then went on, and in 2014, she went to somewhere that was starting to do endovenous ablation, the proper way to do veins, the thing that I introduced into the UK in 1999. But unfortunately, in 2014, she was still given a general anaesthetic. And really, since 2005, anywhere that gives the general anaesthetic for varicose veins is way behind the curve, because all of the new techniques are designed to be used under local anaesthetic, not only for cost but also for safety for the patient and for efficacy. We need feedback from the patient. Unfortunately, she then went more recently to one of these cheap network clinics on the high street, and she had a further procedure which didn't give her much improvement at all. So she then came to the Whiteley Clinic and she said, okay, let's see what's actually going on. And now I'm going to go through what we've found since she's come to see us. So first of all, she's telling us she's got recurrent varicose veins, and you can see here some photographs. This is a photograph of the back of her legs. You can see some varicose veins and some thread veins on her calves. And this is the front of her legs, and on her left leg you can see a varicose vein above her knee, and you can see some varicose veins below the knees on both sides. And these are the typical ones from the side. Now, the difficulty always with doing clinical photographs is they're always difficult to see with varicose veins, but the lighting is difficult. So at the Whiteley Clinic for the last couple of years, we've been using infrared spectroscopy, and now you can see this is the infrared image. What happens in infrared is varicose veins are very hot, and so they appear as yellow. The other areas of the leg appear more purpley red. And you can see here she's got quite a lot of varicose veins in her upper thighs from the front. From behind, she's got a lot of varicose veins in both calves, and again the infrared shows that very clearly. And then when we look from the sides, you can see she's got profuse varicose veins all the way over the bottom of her thighs on both sides, going out on the lateral side and also a bit on the medial side as well. So we know she's got gross varicose veins, but despite that, she's only recently been to one of these cheap network clinics. So they shouldn't have this because she had full treatment and was signed off for them as saying that she was cured. So this then is the scan that she had with our vascular clinical scientist, and all of our clinical vascular scientists or vascular technologists are trained, not only fully trained as vascular technologists and go through a full degree or their full training, but also when they come to the Whiteley Clinic they undergo further training so they are up to scratch with the Whiteley protocol. So as you can see here, the first image is of her right leg. Now, I'll just explain this to you. These veins up at the middle of the image are the deep veins. The bigger lines on either side are what's called the truncal veins or the venous veins, and then all the other veins in between are any abnormal veins or varicose veins that we can see. Blue is normal, and as you can see, there's not an awful lot of blue here. Blue means that the valves are working and blood is pumping up to the heart. Red means that the valves aren't working and blood is refluxing. It's going the wrong way when the patient stands up, and those are the varicose veins. These are the underlying cause of the varicose veins, one should say, because this is the problem you can't see on the surface, but this is where the veins are coming from. Much more importantly, and what these cheaper clinics are just not looking for because their scans are not intense enough, they don't really spend enough time doing them with trained people, is the purple veins. These are called incompetent perforating veins. And a lot of the work that we do at the Whiteley Clinic is with people who have had treatment elsewhere, and when they come to see us and say, but why have our veins come back? It's often because they haven't had the incompetent perforating veins treated. And as you can see, there's a lot of them on this patient. Finally, you can see also the red veins coming right from the very, very top. And that's because this patient also has pelvic congestion syndrome or pelvic venous disorders. In other words, varicose veins inside her pelvis, which are coming to the legs. So yet again, this is another thing that's being missed by a cheap and quick scan by someone who doesn't know what they're looking for in venous disease. So if we look in order with this patient, you can see her small venous vein on the left is completely red. So they've completely missed the fact she's got reflux in her small venous vein. The black areas are those bits that have been treated. So she's had the top of her great venous vein and the anti-accessory venous vein, those two black lines at the top, they've both been treated okay, except when you come down the main vein on the right, called the great venous vein, you can see a patch of red, and you can see those purple veins coming into it. In other words, she's got incompetent perforating veins coming out and reconstituting the vein that wasn't fully closed. And as you can see on the right-hand side, she's got 12 incompetent perforators. Research we're just about to publish from the Whiteley Clinic by my colleague Professor Barry Price, that's been presented around the world at international meetings, shows that if you have 3 incompetent perforators or more, that gives you the same damage as if you've got one great venous vein or one small venous vein that's incompetent. So with 12, this is as if she's really had no treatment at all. The fact is she's also got blood coming out of pelvic varicose veins. So if we look at this and we think how many veins are causing her vein problem, great venous, anterior accessory venous, small saphenous, 12 incompetent perforators, that's 15, and pelvic veins, and I'll show you in a minute, there's 2 on each side in this patient. That's 17 veins that she had that are causing her underlying problem. All the treatment she's had so far, from the initial stripping all the way through to the recent cheap vein clinic that she went to, have only addressed 2 of those veins. So not surprisingly, she's still got her veins. It's not so much they've come back, it's just they've never been treated properly in the first place. Let's look at her other leg. So we're going to look now at the left leg, and once again the same colour scheme. The deep veins are the blue ones here, so her deep veins are normal. That's great because we can actually correct most of the problems she's got. You can see on the right side this time, because it's the other way around, this is the left leg, you can see that they've treated her small saphenous vein successfully, that's black, and the top of her great saphenous vein, that's also black. So that's not too bad treatment. But they've completely missed the red vein at the top and on the left. That's called the anterior accessory saphenous vein, and that's big. That's 9 millimeters. It should only be 2 millimeters, and that's a linear. So 2 by 2 diameter. It is the area. So obviously it's a circle, but you can make it roughly 4. If this one is 9 by 9, about 81. So you can see the great big dilatation that she's actually gone through to dilate this vein up to being how big it is. It's massive. It's about 20 times bigger than it should be. And that's, of course, one of the major reasons she's got varicose veins. On this side, she's only got 4 incompetent perforators. But as I've just said, 3 or more gives you the same reflux as if she hasn't had a great saphenous vein treated at all. And on this side again, she's got incompetent pelvic veins. So if we count up on this side, 3 truncal veins, 4 perforators, 2 pelvic veins, you can see, and she's only had 2 of those treated. Not surprisingly, that's why she's got all of her veins back again and her symptoms. So at the Whiteley Clinic, we now know that she needs to have the truncal veins treated by endovenous laser ablation under local anaesthetic. She needs to have the trollop procedure to get rid of her perforating veins, but we don't know what's going on inside her pelvis. So under the Holdstock-Harrison protocol, which is the world leading way, and we've published in 2006 that this is the correct way to look for pelvic veins, it's far superior to the static lying down imaging such as CT, MRI, or even venography, because all of those just show if the vein's there and if it looks a bit dilated. Only the duplex ultrasound using the Holdstock-Harrison protocol shows is the vein working or not. So this diagram here shows the pelvic veins, and once again, blue is normal. You can see blood coming up from the deep veins in the pelvis up towards the heart. That's that blue inverted Y in the center of the picture. However, the ovarian veins, the 2 long red ones, are both totally incompetent. If she was a man, she would have varicose veins around her testicles, and she would have been referred a long time ago because those would be called varicoceles. Because she's a woman, you don't see those varicose veins, and so she's been ignored. And even though she gives symptoms when you ask her of pain in her pelvis at certain times, it's been ignored because nobody looks for pelvic congestion syndrome, particularly not the gynecologists. But importantly, she's also got pelvic vein reflux in her internal iliac veins and pudendal veins. So she's got the worst possible reflux in her pelvis. This is called 4-vessel disease. So basically, this poor lady has been going around with reflux in all of 4 of her major pelvic veins. She's been going around with reflux in her truncal veins and incompetent perforating veins, and all of these are causing inflammation at her ankles, which are causing her symptoms, swelling. If they're not treated, they will go into brown stains, ulcers, and as we now know from the recent research, also increased risk of heart attacks and strokes and dementia, which is all being shown as an association now, and that's all well published because of the inflammation caused at the ankles. And she's been to different vein places, and each one of them has so far only diagnosed the easy to treat truncal veins in the legs and offered treatment for those. Luckily now she's come to the Whiteley Clinic, we'll be able to treat her truncal veins after we've treated her pelvic veins first, and then we can treat the remaining truncal veins that haven't been treated, the anterior accessory saphenous vein and the little bits haven't been treated properly. But most important, we can also then treat our perforators, and we can actually set her back to having no reflux at all. And this is why we can get patients back to having the lowest possible chance of recurrent varicose veins in the future, because we treat all of the different points of the reflux, not just the easy to treat ones that the cheap vein clinics do.